Hi friends, welcome to yet another session of Dr. Sahasranam's ECG quiz. Today I have lined up for you one 12-lead ECG and two arrhythmias. I hope you are ready, armed with your pen and paper to answer the quiz. We'll go on to the first ECG. Now this is the ECG of a 45-year-old smoker who was brought to the hospital with a history of chest pain followed by a transient loss of consciousness. What are the ECG findings which you see in this picture? What do you think is the cause for the ECG changes? That means what is the clinical diagnosis of the patient? And what could have been the cause or causes for his transient loss of consciousness? So you can start answering the quiz and maybe I'll give you about 2 to 2.5 minutes time. Okay. So we will go on to the answers for this quiz. So we'll discuss this ECG. Now what is the striking feature here? It is the slow but very regular heart rate, isn't it? Very slow rate, but it is regular. The P waves are seen in lead 2 and V1. You can see it in other leads also, but I think it's seen better in V1 here. And of course lead 2 is also seen, and they are occurring at a rate of 100 per minute. 3 large squares which I have measured already. So the rate will be 100 per minute, 300 by 3, right? And one thing you find is the P waves bear no relation to the QRS complex. They are seen before the QRS complex, inside the QRS complex, or after the QRS complex. They are seen to march through the QRS complexes. Now if you look carefully here, you can see P waves. These red arrows are showing the P waves. You can see here the P wave is falling on the QRS complex. That is why this QRS complex is taller than this one. Of course, it is here coming after and later, like that. So you can identify all the P waves here, and you find that they are not related to the QRS complex. The QRS complex in their turn are narrow, and they are coming at a very slow rate of 30 per minute. I have calculated the rate again, which is 30 per minute. So what is a rhythm? It is the P waves, because they are dissociated. There is complete atrioventricular dissociation. Sorry. And hence this is a junctional rhythm with an atrioventricular dissociation, or in other words, it is a complete heart block, isn't it? Now, what is the cause for this complete heart block? If you look carefully at lead 2, 3 and AVF, you find that there is an ST elevation with upright T waves, isn't it? The T wave is taller than the QRS. So this indicates a hyperacute inferior wall 2, 3 AVF, so inferior wall myocardial infarction. And you know that complete heart block is more common in inferior wall myocardial infarctions. Now the third question was, what do you think is the cause for his transient loss of consciousness? Of course, as in any infarction, you can have hypotension with a postural fall of blood pressure, and the patient can have a transient syncope. But here, with a complete heart block, you have to consider always a transient asystole which occurs leading to sudden unconsciousness. What is it called? It is called Stokes-Adams attacks, isn't it? So the patient could have had Stokes-Adams attacks due to his complete heart block. Now the third thing which can occur is, in a patient with an acute infarction, you can always have transient periods of arrhythmias, of which ventricular tachycardia is very important. So the patient could have also had transient ventricular tachycardia, which could have caused a transient loss of consciousness in this patient. These are the causes which you have to consider. Now this is an interesting ECG of a 15-year-old girl, 15, who was brought to the emergency with a history of palpitation. The patient said that I am feeling palpitation. But the resident on duty, after examining the pulse rate of the patient, said that patient's pulse rate is rather normal, except from occasional extrasystole. This was a clinical impression by looking at the pulse. But the patient was saying I am feeling palpitation. So the questions here will be, what is the arrhythmia you see in this patient? It's a very simple ECG. And what could have been the underlying illness in this patient? So you can start off answering the question. I'll give you about 2 minutes. That's a very simple one. You don't need much time here. What is the arrhythmia and what is the possible underlying illness in this 15-year-old young girl? So friends, we'll go on to the answers for this quiz also. Now this is lead 1 which I have shown here, and if you look carefully, there are very sharp P waves occurring at a rate of 300 per minute, 5 divisions. 5 millimeters is the distance between two P waves, isn't it? So 300 by 1, that is 5 millimeters, or 1500 by 5 will give you 300. So this arrhythmia is at a rate of 300 is atrial flutter. So that is no doubt about it. That is the reason why the patient. Do you feel the pulsations of the atria? No, you don't feel it. Clinically, can you see the pulsations of the atria? Can you? That is a question you should ask yourself. If you are careful, you can see pulsations of the atria sometimes here. That is, you can see the jugular vein pulsating at a very fast rate like this. The patient was, possibly the resident did not look at it. The resident looked at the pulse and said that the QRS complex is the one which gives you the pulse. That is coming at a rather regular rate. Look at here, it is rather regular, isn't it? But occasionally there is an irregularity, just like here, right? So he possibly thought it is a regular rhythm with an occasional extrasystole which is occurring. The QRS rate, this QRS rate calculated comes to approximately 42 beats per minute. That is 300 divided by 7 divisions comes to 42. So this is atrial flutter with the variable conduction ratio, right? Variable conduction because of the slight irregularity which you see in the QRS complex. Now, we were asking why this QRS is slow. Normally atrial flutter we said is a 4:1 conduction. Rarely you can get more than that, 2:1 conduction, or an irregular conduction which is usually with a rate around 60 to 70 per minute. Here the possibility is that this patient was given some antiarrhythmic drug, we don't know, and that might have caused the transient slowing of this QRS because of its effect on the atrioventricular node. Now, what could have been the underlying illness in this young girl? What do you consider? In India, from where I am there, naturally, first thing you always think of in a young girl of 15 who comes with a palpitation and an arrhythmia, especially an atrial arrhythmia, you have to think of rheumatic valvular disease. Of course, this patient also had rheumatic multivalvular disease. So one point here is the patient was complaining of palpitation, but the resident did not find anything wrong with the pulse. So don't ignore that. If the patient says palpitation, you must take an ECG. And if there is an atrial arrhythmia with a variable block or a regular block or whatever, suppose this was an atrial flutter with a 4:1 conduction, with a P rate of 300, a 4:1 conduction will give you a QRS of 75 per minute, which is absolutely normal. So when you look at the pulse rate will be 75 per minute, regular. And you will think the patient is just bluffing. No. So take an ECG always if anybody complains of palpitation. The second point is if you are good enough to suspect an atrial arrhythmia, which you cannot detect from the pulse, look at the root of the neck or ask the patient to lie down at 45 degrees or even fully and see if there are pulsations which you are seeing at a very fast rate in the jugular vein. This will give you the diagnosis if you are careful. Now we'll go on to the next slide. So this was atrial flutter with a variable conduction ratio. Now this was a 40-year-old smoker who was brought to the emergency with an acute chest pain and some other findings also, which I won't tell you. What are the ECG findings which you see? Now you can see that only the precordial leads are V1 to V6 is given. Limb leads are not given because they were damaged completely, so could not be shown here. And so with this itself you can make a diagnosis. The second question is what could have been the clinical presentation or the clinical condition of the patient when this ECG was being taken or when you saw the patient. Okay, so you can start off answering these two questions. It's a simple ECG. Maybe another 2.5 minutes will be enough for this. So friends, now we'll go on to the answers to this question. Now you see only the precordial leads here. I have told you already. If you look carefully, the precordial leads show an ST elevation, isn't it? An ST elevation in V1, V2 and V3, most important. And the rate of the QRS, if you calculate, that is, these are the small QRS complexes are very tiny in between. The ST segment and T wave is so prominent that the QRS is almost hidden there. But if you calculate the QRS rate from this V6, you will find that it is 2 large divisions, which will be 300 by 2, which gives you a rate of 150 per minute. And the P waves are seen. So the patient is having a sinus tachycardia with a fast rate of 150 per minute. And this ST elevation tells you that this is a hyperacute anterior wall myocardial infarction. It looks suddenly, if you look at this ECG, especially if you are seeing only lead V1 or V2 without being given V5, V6, you may even mistake this for a ventricular tachycardia. So you have to be careful. What you are seeing here is not the QRS, it is actually the STT, which is such prominent, whereas the QRS is very tiny, seen in between these two waves, right? So don't mistake it for a ventricular tachycardia. Now, my next question here was, what could have been the clinical presentation of this patient, isn't it? What is a sinus tachycardia would give the clue to this clinical presentation. A patient with a hyperacute anterior wall myocardial infarction coming with sinus tachycardia. Possibly he could have been in hypotension. The blood pressure could have been low. He could have been even in cardiogenic shock, or he could have been in acute pulmonary edema. These are the three things. Suppose a patient comes to the emergency with an anterior wall infarction, or any infarction for that matter, but anterior wall more common. And that patient is showing a sinus tachycardia without much symptoms. A resting sinus tachycardia more than 100 per minute. When the patient has an anterior wall infarction, you have to anticipate that this patient could go into one of these complications: hypotension, cardiogenic shock, or acute pulmonary edema. So be prepared for that. Get the patient to the cardiac ICU at your earliest, right? So friends, I'm sure that the diagnosis, you would have made this diagnosis in this patient. Now that brings us to the end of today's session. I presume that all of you answered all the 3 questions, 3 ECGs, and answered all the questions correctly. If you have any comments or queries, please post them in the comment box which I have given. And don't forget to hit the subscribe button if you have not already done so. Share this with your friends and colleagues whenever possible. Let this benefit as many people as possible. And so I'll see you again another episode within a couple of days. So goodbye till then. Thank you.